So today my presentation is going to be on inotropics, particularly in the end-of-life care for our CHF patients. So just so that we're all clear, although we're all nurses, we're not all cardiac nurses, so just a brief overview. Congestive heart failure is, as we know, a failure of the heart muscle to contract efficiently, which is measured by an ejection fraction. Specifically for this presentation, we're going to be looking at patients that fall into the ACC stage D or the New York Heart Association functional stage 4. So these are basically heart failure patients with multiple comorbidities, heart failure with renal failure, heart failure with chronic lung disease, heart failure with dementia, heart failure with cancer. Or these patients might be your elderly, progressively frail patients, or when patient preferences shift the emphasis of care to quality of life. So these end-stage CHF patients can be difficult to manage effectively and consistently. That's a particular concern. This is due to variations in medication responses and strict diet control by the patient, which we know is like fluid and sodium restriction. So this is frustrating for patients and providers. Brief overview of what an inotropic drug is. Basically, these are drugs that increase myocardial contractility. There's basically 3 drugs that fall into this category: dopamine, dobutamine, and milrinone. We're not going to get into all the physiology of how they work, but basically what you need to know is that an inotrope will make the heart muscle squeeze. So we're going to hopefully get some improved ejection fraction numbers with the inotropes. So these drugs are powerful, but they also have a lot of side effects associated with them. And in our end-of-life care patients, we have to gauge the risk versus benefit. As with everything, we have to judge if this is going to be beneficial for these patients or not at end of life. Some of these side effects are dose dependent. So for example, under 10 mics a kilo per minute, dobutamine will have a vasodilatory effect on renals and mesenteric arteries. At doses above this 10 microgram per kilo per minute dose, we see enhanced vasoconstrictive effects. This is important because depending on what kind of side effect you're trying to get out of the patient, what kind of therapeutic achievement you're trying to get from these drugs is going to be dose dependent. So something important for nurses to take into consideration and know. In end-stage heart disease, we typically will see the lower values. Basically, we're trying to increase blood flow to the kidneys so we can diurese these patients, get rid of some fluid, and increase the patient's, or decrease the patient's shortness of breath. So how do we use this in palliation? What is the role for these inotropic drugs in palliative care? So Allen says palliative care for heart failure generally requires an interdisciplinary approach. This includes the primary care, cardiology, palliative care specialists, each represented by various providers, physicians, advanced practitioners, nurses, case managers, pharmacists, and chaplains. Due to the nature of this disease, the heart failure patient will have experienced a burdensome progression of their symptoms over a number of months and years. These symptoms of the heart failure patient are shortness of breath, edema, activity intolerance, just an overall decreased quality of life, and reliance on supplemental oxygen. Because of the complexity of managing these patients, it is important that the provider recognize the involvement of palliative care team in these cases early on. So no doubt most providers will have had palliation on their minds, especially in the primary care setting. It's not very common that these CHF patients will just spontaneously come up with an ejection fraction of 15%. Usually it's a progressive decline that the primary care has been dealing with and has been leading towards palliation. Heart failure can be discovered unexpectedly, but typically you don't just come in again with a super low ejection fraction. Usually It starts off with some swelling, some shortness of breath, some activity intolerance. The patient will subjectively complain that, oh, I used to be able to walk my dog, around the block 10 times, and now I can barely make it down the block before I have to stop for a break. So inotropes are only one of several options that may be available for patients. Some of these are transplantation, LVADs, stuff like that, ultrafiltration. Palliative care should be considered once significant symptoms are present at rest. So that's a key feature of the New York Heart Association Stage 4 heart failure. So palliative use of inotropes for this subset of patients has shown to be effective in reducing symptoms and the discomfort associated with these symptoms. So the question is, with our end-of-life patients, should we be using these drugs? If we know the patient's heading toward end of life, should we be using these drugs that are very powerful, that have a lot of side effects associated with them? Colucci et al. States, use of intravenous inotropes can be helpful in patients hospitalized with acute decompensated heart failure with a low cardiac output and evidence of end organ hypoperfusion or hypotension. Given lack of evidence of a survival benefit and concerns about risk of increased mortality and side effects with their use, intravenous inotropes should not be used in the routine inpatient management of acute decompensated heart failure in the absence of hypotension or organ hypoperfusion. In patients with refractory end-stage heart failure who are ineligible for advanced heart failure therapies, continuous outpatient intravenous inotropic agent infusion may be considered to palliate symptoms. So again, should we use these inotropes? It's a complicated answer. As is the answer to almost everything in medicine, it depends. Because of the variation in patient response to inotropic medications, their use may prove beneficial or they may not. There are relatively high incidence of ectopy and other side effects associated with use of inotropes. They can be considered to improve symptoms in refractory end-stage heart failure. When we think of palliative care, we think of pain relief, improving quality of life near the end of life. The use of inotropes do have several side effects. The most common include increased ectopy, dysrhythmias. If they're going to be infused for longer than 24 hours, they typically will need a central line placed, which obviously opens the patient up for risk of infection. Significant and sudden hypo or hypertension, transient decreases in oxygen levels, higher risk for infiltration and tissue necrosis, and this is particularly if it's given for longer than 24 hours in a peripheral IV. The use of these drugs in a palliative way is a decision that the provider and the patient need to discuss thoroughly to assess the risk versus benefit and appropriateness for the patient's situation and preferences. So the most important thing is, well, what does the patient want? Does the patient want all the intervention done? Do they want minimal things done? Do they want the safest of the 3 drugs? Again, another important thing to discuss with the primary provider. What does the family, the power of attorney want? Always risk versus benefits. Is this patient going to benefit more than the side effects? And is it going to alleviate their symptoms in any significant way? So with the use of inotropes, I know just in our practice at Mercy, we use it quite frequently, especially in our decompensated heart failure patients, although they might not be on a palliative service or a hospice service. We tend to use particularly dobutamine more than the other 2 for renal perfusion to help diurese these patients. A lot of times these patients have some diabetes, some kidney failure associated with that. So we use the dobutamine to perfuse the kidneys, get rid of fluid. It helps the patient feel more comfortable. They don't have near as much swelling. Their shortness of breath improves. Their need for oxygen decreases. So it is essential that these providers are discussing advanced directives with their patients before palliative care becomes a real concern. Especially important in the primary care setting, where long-term planning with the patient and their family can be appropriately assessed. And again, these patients don't present just suddenly with a horrible EF. This has been an ongoing thing over many months, many years. So does the patient or power of attorney want the pharmacological intervention if the physician feels it would be beneficial? The risk of tissue damage and the associated pain with that and subsequent risk of infection, the risks of ectopy and dysrhythmias, risk of complications with hypo or hypertension are very real with the use of these drugs. The decision will have to be made if the potential improvement in CHF symptoms is worth the risk of side effects. Ideally, the patient will have had this discussion in the months or years prior to palliation, and a decision will be in place, hopefully in the form of an advance directive. Any questions? Yeah, if you have a question.
If you have an irreversible congestive heart failure, would they use these drugs to continue a treatment that you know is not going to be successful?
Right. So the difference between, as we know, palliative care and hospice care, sometimes we think of them as one and the same, but palliative care, you can still have curative plans, curative treatments in place. So the goal of the inotropes is to help with symptoms. So the physician and the family have to take into account the risk of, all the side effects that we talked about versus what benefit they might have. If they're already on a palliative service, they could still be looking at transplant, LVAD placement, some of the other therapies, until it's determined that they're either not responding to that, or the family or the patient decides they just want to, kind of have closure to it all, don't want to put the patient through any of this, don't want to subject the patient to the risks of the medications or the treatments, and then that's when it would progress to hospice. And even in hospice situation, these drugs aren't considered cure treatments. They're considered treatments to just help alleviate symptoms to make the patient more comfortable at the end of life. Particularly, again, a big number one with these is diuresing, so that the shortness of breath improves, the oxygen requirements go down, swelling improves, which makes the patient more comfortable.
But there's nothing that will actually improve the heart function.
So with inotropes, they will increase the myocardial contractility, but you can't live on inotropes, right? You can't be on them 24 hours a day, 7 days a week. Frequently what we'll see, not particularly in stage patients, but we'll see patients go out for outpatient dobutamine. So they'll come in once or twice a week to the infusion center, they'll get an infusion of dobutamine just to help perfuse, and they'll get rid of a lot of water, they'll diurese, their activity tolerance improves, their shortness of breath improves. Is it a curative treatment? No, it's not, but it's simply there to increase quality of life. Now, these drugs can be used in a life-saving manner if you have an acute episode of particularly hypotension, cardiac shock, cardiogenic shock. They'll use these as vasoconstrictive agents to increase blood pressure. But in the end-of-life patient, the palliative patient, it's pretty much strictly for symptom improvement. All right, thank you very much.